Good morning, everyone, and thank you for joining us for this week's virtual journal club. And my name is JP Britton, endocrinologist at Mayo Clinic and co-host of these sessions. Today we have two wonderful speakers, Dr. Wasserman, who will be presenting his publications titled Lung Metastasis in Children with Differentiated Thyroid Cancer, Factors Associated with Diagnosis and Outcomes of Therapy. And we also going to have our discussant today, Dr. Martinez-Rios. Dr. Wasserman is a staff endocrinologist at the Hospital for Sick Children in Toronto, where he maintains a clinical focus on treatment of pediatric endocrine neoplasms and endocrine sequelae of childhood cancer therapy. His primary research focus is in genomics on childhood endocrine tumors, as well as the healthcare utilization among children treated with endocrine malignancies. He is also the co-chair of the American Thyroid Association Pediatric Thyroid Cancer Guideline and is a member of the Children's Oncology Group Endocrine Long-Term Follow-Up Task Force. Dr. Martinez-Rios is a former research fellow at the Department of Radiology at Children's Hospital of Boston, Harvard University, and a former visiting faculty in the Department of Radiology at the University of Hospitals Rainbow Babies and Children's Hospitals at Case Western University. Her primary research focus is on thyroid carcinoma in children and cancer predisposition syndromes involving thyroid gland, as well as the ultrasound CT and MRI imaging in children. She's currently an assistant professor in the Department of Radiology at the University of Ottawa and radiology staff in the Department of Medical Imaging and the Children's Hospital of Eastern Ontario. Now I will turn it over to you, Dr. Wasserman. Thank you very much for being with us.
Thanks so much, JP, for the introduction, and to the Thank Foundation for the invitation to present this journal club. And just before we started the webinar, we were discussing that this is probably the first all-Canadian journal club that the Thank Foundation has hosted, at least for the speakers. And as a bit of a preview of what's to come in the next hour, we've started this as a sneak peek of what's coming forward. Was asked to present this paper that we published a year ago, Lung Metastasis in Children with Differentiated Thyroid Cancer, Factors Associated with Diagnosis and Outcomes of Therapy. And to give credit where credit was due, this is largely the work of a fantastic fellow who's now staff at Great Ormond Street in London. That's Alex Chesover, and he put a tremendous amount of effort into this and did a great job. So he may be on the line. If he is, kudos go to him. And this started when Alex was a first-year fellow and seeing patients in clinic with me, and he saw this young man, AR, who was a 10-year-old healthy boy who had presented to one of our community hospitals with some left-sided chest pain. A chest x-ray at the time showed innumerable tiny nodules in the mid-lower lungs bilaterally, and he was actually referred to our facility to evaluate for tuberculosis. He had a recent exposure with a positive individual. After a number of days at our facility, all of his infectious workup had been negative in detail, and an ultrasound of his neck was obtained. And I won't try to take my colleague Claudia's job, but this is the ultrasound. And what's shown here, for those that aren't familiar, this is a transverse view of the neck with the trachea and midline. And notably, the left lobe of the thyroid shows fairly diffuse echogenic foci, much more so than on the contralateral side. And this turned out to be consistent on pathology with the diffuse sclerosing variant of papillary thyroid carcinoma, something that we see fairly frequently in the pediatric population, but is quite rare in adults. Further workup included this CT scan of his chest at the time of diagnosis. And you can see multiple, innumerable sub-centimeter pulmonary nodules throughout the lung fields. He went on to treatment with radioactive iodine. He received 146 millicurie, which is roughly the equivalent of 175 adjusted for his body surface area. And at the time of his treatment, his TSH stimulated thyroglobulin was as stated here, 5,709 nanograms per mil, and this is his post-treatment whole body scan. 2 years later, although his thyroglobulin had gone down a little bit, it was back up to more or less what it had been at the time of diagnosis. He did have some radiologic progression based on serial CTs. And very importantly, he remained completely asymptomatic, had no dyspnea, normal oxygenation, and normal exercise tolerance. And so, this prompted Alex and I to get into a discussion, and these are some of the questions that he had hoped to answer at the onset of this study. Specifically, what is the contemporary rate of distally metastatic disease in children with sporadic PTC? And so these words are chosen carefully. Much of the data that were available at that time reflected series, at least in children, series related to survivors of the Chernobyl incident. And there wasn't much known about the typical child that we see in our practice these days, the radiation unexposed child, the sporadic papillary carcinoma. I wanted to know what clinical features characterize these children who develop distally metastatic disease. Who are these children? What does their disease look like? And are there ways that we can anticipate which children are at risk? What are their short-term outcomes? How often do these children achieve excellent response to therapy? And do these outcomes inform how we approach their initial therapy? And finally, what are the oncogenic drivers in distally metastatic disease in children? This was a retrospective single-center cohort study. We're a tertiary care facility, the largest in Canada, and this was conducted over a 20-year period. All patients were diagnosed prior to their 18th birthday, as is our practice. And in total, there were 93 consecutive patients over the study period. And he looked at 74 patients without distal metastases as compared to 19 patients with distal metastases. All but one were patients that had initially presented and had the entirety of their care at our facility. And starting in 2006, which was midway through this study period, our facility had adopted a fairly standardized treatment protocol, prior to which treatment was predicated largely on the individual clinician's preferences. Of note and relevant to this study, it is our practice at this facility to transition all patients to adult care at the time of their 18th birthday. And this impacted the follow-up time, and I'll get into that towards the end of the talk. And very importantly, around the time that this study came out, there were a number of other very relevant studies. And so this is really only part of the picture that now exists in terms of characterizing this population of children with distally metastatic disease. And I'll just point out that first in 2018, a group from Shanghai published their experience of pulmonary metastases in children. Subsequently, a group from Saudi Arabia in 2019 published their findings. And just earlier this year, a real tour de force from my colleague Steve Waxback and his colleagues at MD Anderson Center in Houston, with an extremely large series over a 70-year period at their facility, largely based on referrals in from surrounding facilities. So this is part of the picture, and I think putting this in the context of the other studies is really starting to help us understand who these children are and how their disease behaves. At the outset, we looked at what published data existed, and based on a number of case series that are listed here, the rate of distally metastatic disease in children was thought to be somewhere between 15 and 25% of those under age 21 with papillary thyroid carcinoma. And in contrast, this was about 2.5 to 5 times the rate in adults. So significantly higher prevalence of distally metastatic disease in children. And when I do say distally metastatic disease, it's almost exclusively, not entirely, but almost exclusively pulmonary metastases that we see. To explore this a little bit more, we looked at the SEER registry, which is a large cancer registry across the United States, and broke it down by age, and that's shown here. You can see that there's a significant change in the prevalence of distally metastatic disease across the age spectrum, with the youngest children seeming to have the highest prevalence of distally metastatic disease, shown here in orange, and that decreases over as they approach adulthood, stays stable, and then slightly increased towards their 7th, 8th, and 9th decade of life. And this is probably largely attributable to dedifferentiated disease, whereas in childhood, this is exclusively well-differentiated thyroid carcinoma. So I'm going to start moving into some of the data from Alex's study. First, this is just showing the characteristics of those without versus those with pulmonary metastases. And as we, consistent with the prior case series, about 20% of our population of consecutive patients presented with pulmonary metastases. Who were these children? Well, we broke it down by age. You can see that children under 13 years of age constituted 43% of all the cases that we saw, but 84% of those with distal metastases. Flipped on its side, among children under age 13, or the preteen group, 40% of those patients had distally metastatic disease. In contrast, the teenagers only had about 5% M1 disease, or distally metastatic disease. So this really seems to be primarily a disease of the preteens, and that fits with those SEER data that I showed you on the previous slide. In our population, not surprisingly, there was a female predominance if you look at the total cohort, but when focusing on only those with distally metastatic disease, the ratio approached 50-50. We looked at the underlying histologic architecture, and there seemed to be, as with our patient, a trend towards excess in the diffuse sclerosing variant of papillary thyroid carcinoma, with 33% of patients with the DSV presenting with distally metastatic disease, although this didn't achieve statistical significance. However, those with other subtypes, including the more common classical and follicular variants, had a much lower rate of distal metastases. And I suspect with larger numbers, we may see this emerging as statistically significant. Looking at T stage, those with with T3 and T4 disease were more likely to be diagnosed with distally metastatic disease, not surprisingly. There were no patients with micro papillary thyroid carcinoma that developed lung metastases, and all patients that had T4 disease were associated with distally metastatic disease. Looking at the individual tumor sizes, Alex did this receiver operating curve and found that diagnostic accuracy was maximized at a diameter of 3.25 centimeters. And this had a sensitivity of 67% and a specificity of 71%. But I do caution the use of size as a predictor in children, because in a growing gland in a child, the size of the tumor is relative to the absolute size of the gland. So a 2-centimeter tumor in a 5-year-old is not the same as a 2-centimeter tumor in a 15-year-old. So I'm really not sure that either size or T stage is particularly valuable as an absolute value in this series or in this population. And finally, lateral neck disease was strongly associated with distally metastatic disease. There was one patient with N0 disease who had skip metastases to the lung, and 3 patients with disease confined to the central neck, but most patients, 68%, had N1B or lateral neck disease. Moving from there, Alex wanted to understand, are there individual features of the tumors or of the patients that might predict the absence of distal metastases? Are there patients whom we can feel reassured don't need evaluation for distal metastases? And this is a univariate analysis. The variables are listed here on the table, comparing M0 to M1 disease, or no distal metastases, to those with distal metastases. It's a very busy table, so just to pick out some of the highlights. Predictors of M0 disease are those without distal metastases, with a negative predictive value greater than 90% included the smaller tumors, T-stage below T3, both clinical and pathologic and zero disease, and those with a post-operative but pre-ablative TSH-stimulated thyroglobulin under 2 nanograms per mil. And I mention that because prior to 2015, it had been the practice at this hospital that almost every patient underwent radioactive iodine ablation post-operatively. So these are all pre-ablative values. This shows the post-operative stimulated thyroglobulin values and those with distally metastatic disease versus without distally metastatic disease. And this is a bit of a no-brainer. You can see that there's considerable overlap. And certainly this alone is inadequate to predict distal metastases. Again, looking at this on a receiver operating curve, if we wanted to maximize sensitivity using a cutoff of 11 nanograms per mil achieves a sensitivity of 90.9% and the specificity of 69%, but to maximize accuracy using a cutoff of 23 post-operative gives us an 82% sensitivity and specificity. And I would note that looking at other series, these cutoffs tend to be fairly different from series to series. So again, not sure that this in and of itself is a useful tool, but although in combination with other factors may be used. The next question that Alex was looking to answer was when in the course of therapy are these individuals with distal metastases identified, or when is their metastatic disease identified? Is it present at time of diagnosis, or is this something that develops later on in their course after initial therapy? And that's summarized in this table here. Each patient is identified here with their age at diagnosis, the histologic variant associated with their diagnosis, and shown here is their time to the diagnosis of lung metastasis in months. And to summarize this briefly, 17 of 19 patients in this series, or 89%, were identified within 6 months of their index surgery. So by index surgery, that means either their initial diagnostic lobectomy or their initial total thyroidectomy if they underwent primary total thyroidectomy. There were 2 patients that were identified later in their course, and I'm fairly convinced that these are true late emerging distal metastases. In one patient who was diagnosed 8 years after initially presenting, had undergone a normal whole body scan 2 years previously, and identification of structural disease was preceded by rising anti-thyroglobulin titers. In another patient, their distal disease was diagnosed 4 years after their initial diagnosis, and this individual had rising thyroglobulin, a normal whole body scan, but did undergo PET and CT, and it demonstrated non-avid disease, which is quite rare in this population. We looked at the patterns of lung metastases, and I'll show you on the next slide what I mean by this. Patterns of metastases were subdivided into these 3 categories. 58% of individuals had diffuse bilateral disease. This is shown here on the uptake scans, where no discrete lesions could be identified. About 20% had focal nodular disease, and you can see that here with punctate uptake, which was often correlated with findings on cross-sectional imaging. And there was one patient who had both diffuse pulmonary disease, and it's hard to tell on this image, it was hard to window it, but there was an isolated pulmonary nodule as well, indicated by the arrow. And breaking these down, there did not seem to be any clear association between the pattern of metastases and either the histologic variant, the oncogenic driver, which I'm going to come to in a minute, demographics, or outcome. So we did, in those patients for whom we had an appropriate tissue sample available, then proceed to genomic analysis of the tumor. These data are summarized in the final column here. This was done either by direct RT-PCR or via RNA-seq for those tumors which did not have a conventional oncologic variant. I've summarized those data here, and you can see that the vast majority of children with distally metastatic disease had tumors driven by oncogenic fusions, and only 22% had tumors driven by point mutations, the BRAF or the NRAS mutation. And in all those tumors which we were able to subject to genotyping, we were able to identify an oncogenic driver. And I'm comparing these data to those data from the MD Anderson series that I mentioned at the beginning of the talk, and you can see that the distribution is quite similar, where once again in their much larger series, they looked at 64 tumors. Oncogenic fusions were by far the dominant drivers of these tumors, with a minority of tumors driven by a BRAF mutation. And in their series, 20% of tumors didn't have an oncogenic driver, although most of these were not subject to what they called comprehensive testing and were only evaluated for BRAF. If you look at those that did undergo comprehensive testing and still had no driver, only 5% had nothing identified. So this presents a spectrum of genomic etiology quite different from that seen in adult thyroid tumors. And finally, radioactive iodine therapy may be effective in treating distally metastatic disease. This is one of my patients, one of the patients included in this series, and this was her radioactive iodine post-therapy scan at the time of her initial treatment. You can see there's diffuse nodular disease throughout the lung fields, and her stimulated thyroid globulin at this time was 81 micrograms per deciliter, or nanograms per liter. Just over a year after treatment with 150 millicuries, her scan was completely clear and her thyroid globulin had decreased to 2.5. Again, this is a TSH stimulated value. And a further year and a half later, with no further treatment, her thyroid globulin had decreased to 8.83 micrograms per deciliter. So this was a very positive response to therapy. When looking at the series in total, however, only 16% of patients in this series over the median follow-up time of 5 years achieved an excellent response to therapy, as just defined in the ATA guidelines. 5% had biochemically persistent disease, 68% had structurally persistent disease, and 11% had indeterminate disease. And 18 out of 19 individuals were alive at the time of last follow-up at our institution. Patients underwent a median of 2 courses of radioactive iodine therapy, but anywhere from 1 to 5, with a median activity of 246 millicuries. This final table summarizes those outcome data, and I've highlighted those 3 patients who did go on to achieve a complete response to therapy. Again, looking to those other series that I mentioned, we wanted to know whether this was typical, and we were somewhat disappointed, but not surprised to find that our experience of a 16% complete response rate was somewhat in line with those other 3 series, where the Shanghai group found 8.5% achieving a complete response. There were no complete responders in the Saudi Arabian study, and in the Houston study, there was a 7% complete response rate. The limitations of this series are those inherent to any retrospective study: incomplete data and the inability and the lack of standardization of treatment approaches. This was conducted over a 20-year period from the late 90s into the late 2010s, and over that period of time, approaches to treatment of pediatric thyroid carcinoma changed. Fortunately, we had some uniformity of treatment at our institution starting in 2006, and then in 2015, with the release of the initial pediatric guidelines from the ATA, we adopted those. There was a relatively small N. We only had 19 patients with distally metastatic disease, which does limit the generalizability of these data, although this is one of the larger series that existed. And we are only able to genotype about 50% of the tumors. And finally, as I mentioned at the beginning, this is a pediatric cohort, and patients were lost to follow-up at age 18, not lost to medical follow-up, but lost to our follow-up. And we did not have access to their subsequent outcome data. The median age of diagnosis in this series was 13 years, and so not surprisingly, the median duration of follow-up was only 5 years. So we did have a lack of long-term outcomes. But to address the question of long-term outcomes, I will, before wrapping up, turn to this data from the Mayo Clinic, from Ian Hayes' group, looking at their experience at the Mayo Clinic, where they did follow patients over a lifetime. And this is 80 years worth of data. I'll bring your attention to this figure here, which is those dying from PTC. And the data are shown here in red, that in children, there was 0% 20 and 30-year cause-specific mortality. Children are not dying of distally metastatic disease, and you have to contrast this with the mortality rates in adults. This is a big difference between those diagnosed with distally metastatic disease in children, where we max out at stage 2 according to the AGCC criteria, versus the adults where distally metastatic disease is considered stage 4. It does present some therapeutic challenges to those of us who care for these children. The long-term survival is excellent, and this is very fortunate, and it's something that is really important for those of us who care for these children to impart to patients when distally metastatic disease is identified. Their survival and their prognosis is highly favorable, and these patients are living with good quality of life and good health-related quality of life. But cure is rare. 16% in our series and less than 10% in all of the other pediatric series in contemporary literature. This means that survivors are living with their disease for decades. It also means that survivors are living with the sequelae of their treatment for decades. That includes the radioactive iodine, as well as targeted therapy in the modern era. And so one does need to consider the need to treat towards complete response versus to manage these patients expectantly, provided they are asymptomatic and maintain good quality of health. I did like a statement from this systematic review, which was published in 2010, which highlighted that the majority of pediatric and adolescent patients with well-differentiated thyroid cancer and pulmonary metastases do not achieve complete response to therapy, exactly what we found in our series. Yet disease-specific morbidity and mortality appear to remain low. It is therefore prudent to use caution in the repeated administration of radioactive iodine to such patients to ensure that adverse effects of therapy do not cause more harm than good in a disease that has an overall favorable natural course. And I think this is very important to those who care for these children, particularly if they're not seeing a lot of patients with distant metastatic disease. So just to wrap up, there are 4 recent series. This one comprises one of them, looking at pulmonary metastases in children and adolescents with differentiated thyroid carcinoma. Distally metastatic disease, primarily pulmonary disease, presents in 20% of children with PTC. The majority of pediatric M1 or distally metastatic disease is identified in preteens and children under 13 years of age. And in that age category, at least in our series, 40% of those individuals had distally metastatic disease. Distal disease is associated, as I said, with young age, larger tumors, with the caveat that tumor size is a relative factor in children with a growing gland. And so we can't really use absolute size cutoffs to predict distal metastases. Certainly those with lateral neck disease are at higher risk, as are those with elevated postoperative stimulated thyroglobulin levels, and oncogenic fusion-driven disease seems to predominate. Disease is typically identified shortly, early in their disease course, most often in the context of postoperative staging. Persistent disease is common despite treatment, and prolonged disease-specific survival is excellent for decades, notwithstanding persistence of disease. And so it's important for clinicians to balance the intensity of treatment with patient's symptoms and progression. The harms of treatment may exceed the harms of stable, persistent disease. And finally, tumor genomics may identify therapeutic options for those that merit systemic therapy. In this series, 4 of those patients did go on to initiate systemic therapy, and 8 out of the 9 had tumor genetics that led to an available targeted therapy existing that would have been an option for them had they needed it. Only 1 with an NRAS-driven tumor did not have an available option. With that, I'm going to hand the baton over to my colleague up in Ottawa, the nation's capital, Dr. Martinez-Rios.
I like that. Thank you very much. Can you see my screen?
Yes, we can see your screen.
Okay, perfect. Thank you very much for the kind invitation to participate in this event, to the Foundation, to Dr. Camilo Gonzalez, Dr. Brito, and for giving me the opportunity to participate in the Virtual Journal Club. And such an honor to be with Dr. Wasserman and sharing the screen. Thank you very much. So I don't have any disclosures apart from that I am a pediatric radiologist, and I know this is mostly a community of endocrinologists, so please bear with me, be patient, and if I say something, please go refer to Dr. Wasserman for clarification. But before to start, I just want to say an excellent paper from Dr. Wasserman with Alexander Chesover and collaborators. So they presented a study on lung metastases in children and adolescents with differentiated thyroid carcinoma. And they identified 20% of patients with lung metastases in their cohort. So the associated factors that they found with in patients with lung metastases was younger patients, less than 13 years of age, larger tumors, regional lymph nodal metastases, elevated postoperative stimulated thyroglobulin, also elevated basal presurgical thyroglobulin in a short sample of the patients. They also found an excess of males, like we know it's most common seen in females, but in this cohort, when they were adapting the numbers, they saw that there was excess of males. There were also excess of patients with diffuse sclerosing variant papillary thyroid carcinoma with lung metastases. And they found that most of the patients were seen or identified within the 6 months from thyroidectomy or the initial surgery for initial staging. So the topics that I thought it was important to discuss and are relevant for this article as well. And I think going hand with the excellent discussion from Dr. Wasserman is what are the current recommendations for pre and post-operative staging of pediatric thyroid carcinoma? Well, if there is any staging system that has been validated in children with thyroid carcinoma, and what staging system is recommended otherwise? I would like to highlight as well the differences between pediatric thyroid and adult thyroid carcinoma. And also at the end, I will discuss briefly about the short and long-term outcomes in children with papillary thyroid carcinoma and lung metastases. So a little bit of the background of thyroid carcinoma in children. So this is the most common endocrine cancer in the pediatric population. And although it is less frequent than in adults, its incidence is rising. The American Thyroid Association, or ATA, has distinguished the distinct behavior of thyroid carcinoma in children compared to adults and has provided the first pediatric focused approach to thyroid carcinoma in children to guide management. And compared to adults, children and young adults, less than 21 years of age, will present with DTC with lung metastases in up to 25% of cases, which is similar to what Dr. Wasserman described in their cohort. Children with DTC have a favorable prognosis despite the lung metastases. So this table, I grabbed it from Dr. Wasserman's older presentation, and this is just to compare the pediatric and adult papillary thyroid carcinoma. So the setting in the pediatric population compared to adults. And as you can see, whenever there is a nodule in pediatric patients, it has a higher risk for malignancy and up to 30%. Also in children, there is increased risk for lymph nodal involvement, for pulmonary metastases, for multifocal disease, and also for risk of recurrence. However, despite all this scenario that looks very, very bad, the patients have a very good survival despite the evidence of metastatic disease. Also, the genetics, the mutation or the derangement in children is different compared to adults, with the RETS PTC mutation most commonly seen in pediatric patients. So rarely familial will be, rarely it's going to be a familiar carcinoma. And when we see pediatric thyroid carcinoma in patients below 10 years of age, it constitutes a higher risk category for poor and with a poor prognosis. So the ATA recommendations have already a setting for preoperative evaluation in children when there is a new diagnosis of a thyroid carcinoma, and includes an ultrasound of the neck to assess the characteristics of the thyroid nodule and the cervical lymph nodes, and to assess if there is any metastatic disease in the neck. Also, for patients that have bulky metastatic disease, the recommendation is to go to a CT or an MRI of the neck to assess for involvement of the aerodigestive tract, neck, or the structures of the neck, vessels, and access to deeper spaces on the neck or lateral neck as well. And however, there is no recommendation or at the first preoperative evaluation to perform either a CT of the chest or a chest X-ray to assess for potential metastatic disease. However, whenever there is a patient that has very bulky cervical adenopathy, the recommendation is also to perform a CT of the chest to ensure there is no metastatic disease, even at diagnosis in the lungs. And then for postoperative evaluation, the aim is to identify persistent locoregional disease or metastatic disease and help to determine which patient will require further staging or further therapy. So for postoperative staging, we focus in the intermediate and high-risk patients with a stimulated TSH thyroglobulin and a diagnostic whole body scan. And it has been described that the stimulated thyroglobulin is a reliable marker for evaluating for the presence of residual or metastatic disease. And in a study that published Lee and collaborators in the Journal of Surgery in 2013, they found that a stimulated serum below 2 nanograms per milliliter has a 95% negative predictive value to assess for thyroid carcinoma. With respect to the staging systems in children, there is no postoperative staging system that has been validated in children with PTC. So the more you look in the literature, you have some articles that have been described the use of the system, however, there is no a system that has been validated in children. The one that is used currently for staging is the tumor node metastasis, or TNM, from the American Joint Committee on Cancer, and is also recommended by the and in children with a cancer, incorporating the characteristics of tumor size, extent of the disease, regional nodal disease, and distant metastasis. So according to the TNM, children will be categorized as stage group 1, with patients that have either N category, however, no distant metastasis, which will be an M0, and stage 2, which will be any T or any N categories, but with distant metastasis, which is an M1. So the TNM classification will help to provide a detailed initial postoperative classification or staging system of this patient. It will classify children into 1 to 3 ATA risk stratifications, which are these 3 groups that I described below, allowing for a better prediction of disease-free stage in these patients, and also identify patients at risk for residual or persistent cervical adenopathy. And as well, it helps to guide further management, identifying patients who will require further postoperative staging or to define the metastasis at distance. So they will require a therapeutic radioactive iodine therapy. So the categories of the ATA are divided into low, intermediate, and high risk, as we have been mentioned. And I will focus only in the high risk, which is the interest of our paper, because it speaks of distant metastasis. And it speaks about the extensive regional N1B disease, which is mostly the lateral compartment, or extrathyroidal invasive disease, or tumors above T4 or the grade T4 in that category, and or distant metastasis, high risk for incomplete surgical resection, persistent disease, or distant metastasis. However, the main limitation of the AJCC TNM system is to define the prognosis and long-term survival in children, which is commonly favorable despite an extensive disease at presentation or disease stability after the therapy with radioactive iodine, which is an excellent survival. Nonetheless, the AJCC TNM staging system is used in an attempt to keep a low disease-specific mortality and reduce treatment-related complications. So just emphasizing the differences of how thyroid carcinoma in children presents and behaves with compared to adults, which is the cause of the limit of the accurate extrapolation and proper application of the TNM system into this population. So the features that we mentioned before is the age of diagnosis, which is younger most frequently, compared to the adults, which of course is now above 55 years of age, where is the category. And then size of tumor, which in children usually are larger tumors at presentation. The extent of disease is advanced disease at presentation as well, or tumor invasion already at presentation. Also, there is a high risk for multifocal disease, lymph node involvement, and as we were mentioning before, pulmonary metastasis, with the higher risk for lesser completeness of surgical resection and higher, per se, higher risk for residual or recurrent disease. So, however, the survival is better in kids compared to adults, and again, the mutational derailment is different. That may have an impact in pediatric patients compared to adults. With respect to the T stage, so tumor extension has been proven to be an important risk factor for pediatric thyroid carcinoma. However, the approach to staging in children and adolescents needs to be reconsidered, as it could offer a clinical utility as a risk factor for lung metastasis. However, data is still limited. And as Dr. Wasserman informed before, so the size of the tumor may vary when, a little kid is going to grow and the tumor is going to change. It's going to occupy most of the time that is very tiny, but then eventually in a larger patient, and like you mentioned, 2 centimeter nodes may not be as important as in a younger kid. But however, larger tumors at diagnosis are the hallmark of younger patients and also in those patients that have lung metastasis, although this association hasn't been consistent. In the study of Dr. Wasserman and Alex Chesover and collaborators, they found like a threshold of the size of the tumor of more than 3.25 centimeters that had a near 67% sensitivity and 71.2% specificity for lung metastasis. So just again, remember that the age of patient impacts tumor size. With respect to the end stage in children, so also the end stage is strongly associated with lung metastasis and correlates with those patients that will require further management. So the higher end stage, the higher risk for lung metastasis. Absent of clinical and histological lymph nodal disease had a negative predictive value for metastasis up to 90% in a study for 90 and 96% respectively. And this was described by the study of Alex Chesover that we just discussed earlier. And also the nodal metastasis may be underestimated as a surgical approach for nodal dissection, since this is very variable between institutions. So also in some different articles that you can find in the literature, some authors have described or indicated that the evidence of N1B or lateral neck should be considered as a strong predictor for persistent recurrent disease, which is similar to what Dr. Wasserman saw in his cohort. With respect to the M stage in children, just emphasizing again that up to 25% of children with DTC will present with distant metastatic disease, usually to the lungs. And the variability of timing of diagnosis of lung metastasis with this in the literature or disease at presentation may be due to a variability of the postoperative staging that is used in different institutions, or the use of initial radioactive iodine therapy in children with respect to adults, etc. But this eventually may be identified with appropriate staging and for the steps of the disease in these patients. So the ATA does not recommend a routine chest CT during the initial staging, as I mentioned earlier, but it is advised whenever there is a very bulky metastatic or adenopathy in the neck, which has been associated with an increased risk for lung metastasis. So as I just emphasizing here, that lung metastases have been associated with a higher end stage of particularly the lateral neck, and larger size of the nodes. So as Dr. Wasserman and Alex Chesover identified in their study, at this stage, less than T3, absent clinical and absent pathological lymph nodes had a negative predictive values of more than 90%. With respect to the detection of lung metastases, in the study of Dr. Alex Chesover, they found like most of the cases were identified within the first or initial staging or the index surgery. And although, however, although there is a risk for late metastatic disease, although rare, it warrants ongoing surveillance in these patients. The other thing that the authors identified were that there was incomplete concordance between the iodine, the diagnostic or therapeutic radioactive therapy, and also between the CT during the staging. So this raises the question if there is differences in the imaging protocol between the patients itself, because they happen over time and they were adapting the protocols as they go. Also, that would depend on how much dose of radiation was given or the quality of the CT, etc. So it may vary. So that was outside of the scope of the study, but that was one of the findings. Sorry. This is just an example from the internet. Like I couldn't find a patient, but this is just examples of CT of the chest with lung metastasis from thyroid carcinoma. And as you can see, the pattern can be as a very few, like a scattered, numerous small subcentimeter nodes in both lung parenchyma to extend to a very profuse and diffuse extensive disease bilaterally with nodules of different sizes throughout both lungs, with almost like a Christmas tree appearance, and similarly with larger nodes in the lungs. So it can be diffuse multifocal with macro or micro metastases with a miliary pattern and may show calcifications. And with respect to the pattern of the lungs metastases, so this is a study from Al-Sarhani. They identified different type of metastases of the lungs with micro or macro lung metastases, and they found that there was no difference between the outcome. Probably because they didn't have enough to defer, and mostly were micro metastases. But for all the patients, there were like not successful resolution of the disease. As you can see here, the response there was a structural disease throughout. Only one patient died. However, the biochemical laboratories were successful in these patients. And just real quick, so this already showed Dr. Wasserman about the pattern that they found in their study in the uptake, and you can find the diffuse pattern, multifocal pattern, or diffuse and solitary pattern. So that's what Dr. Chesover and Wasserman found in their study. And however, they didn't find any association of response of the radioactive iodine treatment or clear association between the pattern of the appearance of the lungs or histologic variant, age, sex, or oncogenic derangement, as Dr. Wasserman informed. So this one already mentioned Dr. Wasserman, and this was from the results of his study. They mentioned that most of the patients had a structurally persistent disease in up to 68% of the cases, but there was an excellent survival. No association between the cumulative radioactive iodine activity or number of radioactive iodine activity courses and a structural outcome. I think I'm going to go a little faster if I am. So this is a study from Dr. Powell Zag, as Dr. Wasserman presented earlier as well. So I want to emphasize as well the importance that this doctor or this is a group of researchers encountered in the systematic review, where they advise cautioning the use of repeated therapy, balancing the risk from adverse events versus favorable outcome, proving that in their study, they found that there was no successful response in the treatment of these patients. And but as well, there was not an unfavorable outcome in terms of death. So there was a good survival. And so with respect to the long-term outcomes, Hay, IT, and collaborators assessed near 190 patients, pediatric patients, in combination with adult patients during 8 decades of thyroid carcinoma. And they found that as well, patients had larger tumors, they were more invasive, they were incompletely resected, they had more regional disease or metastatic disease at presentation, but however, there was no difference in terms of case-specific mortality with compared to adults, and even the rates of recurrence did not differ between children and adults, despite the characteristics of the tumors. So in summary, I want to just emphasize that according to the study of Dr. Wasserman and Alex Chesover and collaborators, that Distal lung metastases in children and adolescents with DTC are not infrequent. However, the outcome is favorable. The associated factors with lung metastases are younger patients, less than 13 years of age, larger tumors, regional metastatic lymphadenopathy, elevated postoperative stimulated thyroglobulin for biochemical and structural persistence, and elevated basal thyroglobulin presurgical, which had an excellent sensitivity. So the difference of how thyroid carcinoma presents and behaves in children and adolescents limit an accurate extrapolation and proper application of the TNM staging system into this population and requires further. Finally, the take-home message is whenever the approach should be multidisciplinary where endocrinologists, radiologists, sonographers, nuclear medicine physicians, and finally, I agree with the study from the systematic review that I described earlier, and also with the conclusions that Dr. that the aim for complete remission must be balanced against the potential harms of cumulative radiation exposure, which are important concepts to explain to people and families and for physicians to consider when discussing their management and treatment goals. So more like a patient-centered approach when dealing with it. Thank you very much. That's my last.
Thank you very much, Dr. Martinez and Dr. Wasserman, for your great presentations. I'm really I don't fully understand something, mostly because there is a paradox here in regards to how frequent pulmonary metastasis happened, how incomplete response persists. So there is some persistent disease, a structural persistent disease that I would imagine might be neck and lung, but probably most lung than neck. Yet these patients do very, very well. So one question is it because the natural course of the disease is that these structural areas don't grow over time, or is because it keep responding to therapy, so they keep responding to radioactive iodine? So, Dr. Wasserman, what has been your experience in regards to response to therapy over time versus just indolent growth of these lesions?
It's a good question, and why the differences in survival between the adults and the children exist is a little bit unclear to me. In direct response to the question, I think for the most part, and this is not universal, it's the former situation that they tend to remain fairly static, not with repeated administrations of radioactive iodine, but they tend not to be progressive. Having said that, and now with targeted tools, therapeutic tools available to us, you know, I'm cautious in terms of selection of patients for eligibility for systemic therapy, but certainly disease progression, despite radioactive iodine, to me, establishes an individual as a candidate for systemic therapy. If they've had one course of radioactive iodine and either don't respond or progress despite that, that's a patient that I would now start thinking about. Is this a child who might be a candidate for RET inhibitor therapy or NTRK-directed therapy? But in terms of the survival, and it's anecdote and partially limited by the fact that we don't at my institution get to see these children with that 30-year window. We really lose them by the time they turn 18. The minority of them show radiographic progression.
Great, and we're having some questions from the audience. One of those is asking for Dr. David Chung. It says, how many times will you administer I-2031 for lung metastasis with less than 25% thyroglobulin reduction before giving up?
As I get older, no, I mean, I think within the question is a really important point, and that is to look at response to the initial radioactive iodine course. If there's minimal response, and I don't know that 25% is the right threshold, but certainly if the response to the initial radioactive iodine is quite modest, that I don't think that the patient has demonstrated that they would benefit from repeated courses of radioactive iodine with the goal of achieving complete cure. It does depend a little bit on what is the initial burden of disease. So if I've got extensive disease like the child that I showed in the initial pictures, where 25% response is still going to leave a massive burden of disease, then I don't think that they're going to benefit from repeated courses, and I'm certainly going to run out my options for radioactive iodine before I achieve much in the way of successful therapy. The 3 patients that did achieve in our series that did achieve complete response, one of them achieved that after a single dose of radioactive iodine, and another one achieved that after 2 courses of radioactive iodine. Those were older patients, so it's unclear whether the 1 course of radioactive iodine would have been enough, because it does take a number of years to see the response. And at that point in time, after a year, if there was residual disease, the approach to care was to give another course. But certainly those that received 3 or 4 courses of radioactive iodine, it didn't do the trick in terms of complete response. And so now, with knowledge about long-term sequelae of radiation exposure, I'm less likely to administer any more than 2, but even the second one is a question.
No, yeah, no, it does, I think. Dr. Martinez, you presented, as well as Dr. Wasserman, the distribution of lung metastases in 3 different patterns. You also showed that they are not really associated with outcomes. I wonder if they are associated with side effects of radioactive iodine, in particular the possibility of pneumonitis with a diffuse pattern.
Yes, and I think it has been described, and even in one of the, Dr. Wasserman, there was in one of the papers, remember that they mentioned that some of the patients developed fibrosis eventually, and there was some, you can see some changes that the lung looks more like almost emphysematous with some streaks, you know, like atelectatic changes are more like bullets, but that's a long term. Like, I don't know exactly if that, at what time or what moment that happens. Like, I don't know how many doses that has to be given to reach into that stage. I haven't read about it. I don't know if Dr. Wasserman has seen it.
Yeah, we didn't look at that, and I think, you know, diagnosis of pneumonitis is a hard one. It's not well captured, particularly in retrospective data. Some evidence or some knowledge, insight into that comes. I think there was a really nice review of the Chernobyl cohort back in 2013. Christoph Reiners was the first author, and they found about 10% of patients developed fibrosis, evidence of fibrosis, and that was after 2 to 12 courses of radioactive iodine, which is sort of has paused to repeated administration. But we didn't specifically look at the rate of pneumonitis or fibrosis as a function of pattern. We don't have those data or the duration of follow-up that would be able to answer that question, but it is an important one because it makes us think about who should get those second and third courses of radioactive iodine.
Yes, and we only have question for one. Sorry, time for one more question. And Camilo asked the recommendation in regards to when a pediatric patient is transitioned to an adult endocrinologist. Recommendations about how to localize disease, but in general, what kind of take-home points do you have for us, the adult endocrinologists, that are going to take these young patients that have a different kind of disease?
Yeah, I mean, I think having this opportunity to present this is important. I know anecdotally, recognizing the outcomes of distally metastatic disease in adults often spooks my adult colleagues out when we transfer some of these patients. And so I think it really is important to recognize the overall favorable prognosis and taking the time to assess the patients in terms of progression of disease and symptomatic disease. These individuals have a long life ahead of them, and it's important to try to not do harm in treatment, recognizing that. but it is challenging. I think recognizing the differences in outcomes when diagnosed in childhood is important, and thinking about how aggressive to be in terms of treating.
Yeah, absolutely. And sorry that we did not get to ask all the questions from the audience. I really want to thank you, Claudia and Jonathan, for wonderful presentations. Thank you very much for being with us.
JP.
Nice, thank you.